I'd like to call the meeting of the Quality and Patient Safety Committee to order. Will the secretary please call the roll?
For the record, Director Masuda Barnett is serving as a substitute member. So Director Kim, Director Sorrell,
Present.
Director Staines is absent, Chair Bott is absent, and Director Masuda Barnett. You have a quorum.
Thank you. The next regular meeting of the committee is scheduled for Friday, August 21st at 9 a.m. The next item is for public testimony. As a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted to the website. Madam Secretary, do we have any speakers who registered to provide in-person or virtual oral testimony or submitted with written testimony today?
We have one speaker, John Stewart. And as a reminder, you have 3 minutes. I'll remind you when you have 1 minute remaining and then when your time is elapsed.
Yes, right there.
Hello, my name is John Stewart. I work in the cardiac cath lab here. Dear Cook County Health Commissioners, we are here to address the ongoing issue of mandatory overtime in the cardiac cath lab and the serious impact it is having on staff, patient care, and the long-term stability of our department. Our cath lab operates on a single shift. At the end of the day, there is no second shift to relieve us. If procedures continue beyond our scheduled hours, we are required to stay until they are completed. Over the past several years, our nurses have collaboratively transitioned from 8 hours to 10-hour shifts to improve staffing coverage for the cath lab. In addition, our cath lab nurses provide emergency on-call coverage 24 hours a day, 365 days a year. We accept the responsibility because patients depend on us during life-threatening emergencies. At the same time, our workload has grown significantly. New services, including electrophysiology, the structural heart program, and pulmonary embolism thrombectomy, have all been added within the same lab using the same resources. Yet we still have only seven nurses. Rather than increasing staffing to meet these demands, mandatory overtime has become the routine solution of chronic staffing shortage to the chronic staffing shortage. The cath lab requires highly specialized skills. While flow pool staff are sometimes assigned to help us, they do not have the specialized training needed for the complex procedures, nor can they relieve our on-call responsibilities. This is especially concerning given the county's investment in expanding the cardiovascular services. Millions have been spent on advanced technology and equipment, but that investment cannot reach its full potential without enough experienced staff to safely operate it. Our staff have worked through every available process to address this issue. Over the past 18 months, we've filed 20 grievances and many have been sustained. We also participated in mediation with the Cook County DHR and presented reasonable proposals to improve staffing and reduce mandatory overtime. Unfortunately, those proposals were dismissed, leaving staff feeling unheard despite our willingness to collaborate. What is most frustrating is that management has repeatedly acknowledged that mandatory overtime is not sustainable, yet the responsibility continues to be shifted on us, the staff nurses who are providing the patient care.
1 minute remaining.
Today, we are asking for your oversight and your support in implementing sustainable staffing solutions. We have adapted our schedules and worked collaboratively to find solutions. We are asking for staffing and resources necessary to provide high quality care. Our department is united in the message. Mandatory overtime is not a staffing strategy. It is a symptom of a system that is failing to adequately support the professionals providing the patient care. The fatigue will lead to burnout, turnover, and difficulty in retention, ultimately affecting the quality, safety, and continuity of care of our patients. Thank you for your time and consideration.
Thank you for your testimony. Is there any other testimony?
There are no other registrations.
Okay, all right. For our next action item, there are no Stroger Hospital Department or Division Chair appointments or reappointments, so we'll move to the next item. Dr. Thomas Patronikos, Stroger EMS President, and Paul Allegretti, Providence Hospital MEC President, will now present their reports and proposed medical staff action items for the committee's consideration. I'll note that there was a correction made to page 9 of your meeting pocket relating to Stroger's Hospital medical staff appointments action item.
Good morning, everyone.
Good morning.
I'm here to present the credentials report for the medical staff at Stroger. If there's any questions, this was approved by our medical staff, and it's presented to the board today.
Oh,
And
Dr.
good morning.
Allegretti.
My name is Paul Allegretti from Providence, and I am here for approval of our reappointments and appointments at Providence. These were approved by the Centralized Credentials Committee end of June, and then approved by MedExec on July 8th at Providence.
I'd like to entertain a motion to approve items 3B, the Stroger Hospital and Provident medical staff appointments, reappointments, and changes as amended.
So moved.
Second.
The motion has been made and seconded. Are there any discussion on the motion? All in favor, say aye. All opposed? The ayes have it. The motion carries.
Thank you.
I would like to just take this moment, if possible, to let you guys know that we are having a medical staff meeting at the old Cook County Hospital in September. And that's, I believe, September 8th. We'll send out an invitation, but we'd like to invite all the board members if they have nothing to do. So there'll be some food, beverages, and then a tour of the old hospital. So,
Thank you for that.
Yep.
The minutes of the June 12th committee meeting were approved by the board in June, but they are presented today for the committee's acceptance. Are there any corrections or revisions needed to be made to the minutes? All right, then I'd like to entertain a motion to accept item 3C, the Quality and Patient Safety Committee meeting minutes for June 12, 2026.
So moved.
Second.
The motion has been made and seconded. Is there any discussion on the motion? All in favor?
Aye.
All opposed? All right, the ayes have it, and the motion again carries. We'll now receive the quality and patient safety updates and dashboard overview, which will be presented by Raji Thomas, Chief Quality Officer.
Good morning, Board.
Good morning.
Morning.
I am sitting in for Danica. Actually, today's presentation is going to be led by Dr. McCormick, who is joining us via team. Dr. McCormick.
Good morning, everyone. Good morning, directors. My apologies for not being there in person. I wanted to follow up on some months ago. We presented to you a new quality structure and a restructure of these meetings, and I wanted to give you a follow up and show you our progress and some places where we have to continue to build our new structure. So if we could move on to the next slide. So as you recall, we spoke about our strategic plan and cascading everything down from our strategic plan in order to build out a system of quality. And we're well on our way in doing so. Part of that is, of course, building dashboards. The dashboards that you're going to see subsequent to these meetings will be demonstrated here today, and will hopefully show a more clear, readable, and concise status of where we are on some key quality indicators and the progress and how we're making that progress. So if you could move to the next slide. So as you recall, we have our strategic plan, and our quality team has the strategic plan that aligns with the system that has produced a new structure where we have formed councils underneath the departments. And so each medicine council has its own dashboard, and these dashboards are demonstrated here. The councils work from those dashboards and look at the KPIs and the metrics that have been felt and worked with our BI partners to be the most, the metrics that will help us move our quality metrics in line with CMS star rating and leapfrog. And that is part of our strategic plan, is to improve those publicly reported measures. So the Medicine Council reviews these things. And when we have issues, and you'll see here on this dashboard, under the safety domain, you can see that in Q3 25 is yellow, there's a green, and there's a red. So I wanted to explain what these meant. The yellow basically means that the KPI is improving, but it's not yet at goal. The green means, of course, that we're at goal, and the red means that we're under goal. So when you see a lot of yellow, that in general means we're improving and progressing. The red means we're having some issues, and we'll continue to work on that KPI. That's what we call our PDSA, where we're plan, do, study, act. And essentially it's hypothesis testing. And after the hypothesis, we continue to hopefully see progress. And if we don't, we go back to the drawing board and continue to dive into the problem. And that's an iterative process throughout quality now. And that process is occurring within our work groups that are formulated by physicians, frontline staff. So we are moving the problem solving to the front line so we can improve and get a more sustainable improvement plan in place. So the next slide should show us the product of the Medicine Council at Stroger. This is hopefully to you all a new format, a new scorecard that's a lot more readable. Just for some explanations, the purple indicators are the indicators that in partnership with our BI team, we have statistically felt that these will most likely, if we improve these, significantly improve our numbers or the factors within leapfrog and CMS star ratings. And so you could think of it as more bang for your buck. And so we're continuing to progress on these measures in purple, but understanding we're running a health system and there's more to it than that. We also have other metrics here that are in the black. And these are the indicators which we might call watch metrics, but these are things that we will always be keeping our eye on. When there are opportunities, which we would see with persistent red, this is when the council will form a work group, which will again consist of frontline staff and frontline management, along with a quality partner, nursing partner, and a physician partnership to work these issues and continue to look at the process improvement opportunities therein. So if you look at some of these, if you look at, for example, iatrogenic pneumothorax, PSI 6, you can see in the first quarter of 2026, we were in the red, and then we are progressing year to date to be in the green. And that's simply because you have pretty low numbers. So any one incident in one quarter will cause you to be in the red. So with these types of measures with low numbers, you'll always see a lot of fluctuation. And so as we track this, we anticipate that at the end of the year, we would still be in the green, but you will see some fluctuation on the red and the yellow. And you can go through this on Stroger, and Donica is on vacation, so I can walk you through these. PSI 6, PSI 11, and PSI 13 are the indicators. You can see that we had some incidents there in Q2, and we are in the red for our PSI 11 and PSI 13. Again, some of those are lower numbers. The sepsis work group is working, and hopefully we will be able to show you at the next meeting some work product from that work group that's going towards improving our sepsis bundle compliance. One of the things I wanted to point out was the hypoglycemia and insulin use. That's a good example of our new system. This is formed a specific work group because you can see that we're significantly out in front of that KPI with a red at 6.23 and then a 5.68. And so that work group is actively working and engaged, and hopefully our next meeting we'll have, we'll see that down into the yellow, and two, you'll see specific work that's being done for that measure. If you look at other measures here, we are pretty much in the green for most of the other measures, with the exception of the MRSA. And that metric, again, sometimes suffers from low numbers. So if you have one, you'll be in the red. And right now, this would be considered monitoring, because what we don't want to do is overreact. And we will monitor this for another quarter and assess and see if we have significant trends in MRSA with regards to location of MRSA infections, types of infections. And then if you go down into the patient experience, you can see that patient experience, we have some improvement in our likelihood to recommend top box at 76, but yet we're not quite at our goal for 2026. And in patient experience, we'll be having a patient experience workshops coming up in August, and we hope to see persistent improvement. And by the end of the year, we hope to be at goal. So this is kind of what we'll be going over with you, but more importantly, we'll be going over the work that's being done on the front line. If you want to move, there's subsequent scorecards. So the next scorecard would be Provident scorecard.
Could you hold on? I have
Sure.
a question.
Sure.
For the MRSA methicillin-resistant staphylococcus, there's a blank space in quarter two. That means there's nothing that occurred. I see there's zeros in some parts, but it's just
Yeah.
a
So
gray
the
box.
date. So what that? Thank you for asking that. Actually, it's something I forgot to mention. We have also worked to standardize all of our data throughout Cook County, and we have standardized to our Vizient partner. Those Vizient partner come out every 3 months. So this is more of a timing issue as far as when that data will drop for us. So the only data that we had to report to you was from quarter one in 2026.
Thank you.
Thank you for the question. Oops, that's backwards. We're going to move
Hold on a
forward.
second. All right.
There. Yes, so this is Provident, and you can see in Provident, now we have a lot less patient volume there, so you'll likely see more green, but the team at Provident is also working on hypoglycemia and insulin, and you can see that they've seen improvement and are headed towards their goal in 2026. The same can be said for likelihood to recommend a top box, that they are at goal already at quarter two. And Dr. Turner, I don't know if you have any other comments, but the scorecard looks pretty good.
Are there any questions?
Okay, so we can move to the next scorecard unless Dr. Turner's got something. Again, ACHN is doing a very good job. You can see through the scorecard with hypertension and the other HEDIS metrics that there is everyone's in the green or the yellow, which either means they're at goal or improving to goal. And again, just to reiterate, the purple really indicates where we'll get most of where we're concentrating our efforts and get most of our improvement effort into the CMS star or leapfrog ratings. And after next. So this is Department of Public Health. We worked with Dr. Joshi, and the team at the Department of Health came up with a really nice scorecard, I have to say. And most things are looking pretty good. I'll let Dr. Joshi comment on the highlights.
Thanks so much for that, Dr. McCormick. Pardon me, Kieran Joshi, Chief Operating Officer, Cook County Department of Public Health. Just a couple of quick comments. As I've mentioned here previously, we're pretty early in our performance management journey. This was sort of a high-level strategic goal for CCDPH for FY '26 was to roll out a performance management system. And so our engagement with this committee has been really helpful in accelerating that. So definitely want to give a shout out to Dr. McCormick, Andrea, and Raji for all their support. So you can see that we've got a mix of indicators here, most of which are sort of what I would describe as operational indicators. Some may be more population level. I think what you're probably going to see is the scorecard change a little bit, because this is really the first time in many years that we asked for leaders within CCDPH to produce performance metrics for the first time in many years. And so we gave them some guidance as to, wanting to produce metrics that were meaningful, wanting to produce metrics that they could influence, and that we could track at a quarterly basis. This is a bit more challenging than you might think, because there aren't existing internal operational data collection systems for public health and established metrics for public health in the same way that there are for healthcare systems. So for example, things like a catheter-associated UTI or a CLABSI, which are, have very standardized approaches across healthcare in the United States, don't necessarily exist for public health. And so again, just wanted to acknowledge the support of the team here, and happy to answer any questions that you may have.
Yeah, the number of naloxone kits distributed went up from 1,300. Is this a trend, or is it's early to say it's a trend, but
Over time, yeah. I mean, this is a
or is
program
it seasonal?
this is a program that we're putting a lot of emphasis on. Some of it may be due to requests. There's a mix of push and pull in that we take requests from the community and we'll distribute naloxone in response to those requests, but we're also pushing naloxone out there through the implementation of naloxone drop boxes across suburban Cook County. That's in collaboration with governments, with community-based organizations across suburban Cook.
And there's no relationship to the number of people that are addicted? That's pretty stable, or when you see an increase, does that mean that more people are addicted to?
No, I wouldn't say that. Again, I think this is an operational measure, and I wouldn't necessarily assert that there's a correlation there with the number of folks that have an addiction per se. Rather, we would look at that data of how many overdoses are we seeing in a given area, potentially other metrics as well, and then try to concentrate efforts in that area. So for example, there are suburbs in the west suburbs, in the western part of suburban Cook County that we know there are higher rates of overdoses in. And so we would put extra effort into connecting with elected officials and try to proactively identify community-based organizations and even private businesses that might be willing to host naloxone drop boxes there.
Yeah,
So it's the other way around in a way.
Yeah, one other question. When you look at workers reached, educated, or trained, you went from 403 to 113,731. That's a pretty big jump.
Yeah, I mean, I think that's ARPA essentially. It's essentially ARPA dollars really accelerating that project.
Okay.
Yeah.
I knew there's something that happened.
I have a quick question. So I can see all the indicators are sort of population level intervention, prevention type of thing. But what about this cancer diagnosis leading to, from abnormal results to diagnosis? It doesn't sound like CCDPH work.
Yeah, that's a great point. And so this is where I think I need to provide some additional narrative to each of these. So as I said earlier, it's actually a mix of some population level measures and some more operational measures. So I'll answer your question, but for example, the staff siren response is a deeply operational measure. Siren is the state notification system that we leverage to make emergency notifications to our own staff. So for example, in response to the poor air quality alerts over the past weeks. We sent emergency notifications to our staff to as to like what safety measures they could put into place. We want everyone to acknowledge receiving that. It's a simple button press on your phone. And right now we're at like around 80%. We were at the 70s previously. So this is a very simple kind of measure of like, I think, basic organizational effectiveness and communication. And I'd like to see us be at above 90%, if not close to 100%. And then we would, probably retire this measure from this dashboard while still continuing to monitor it internally. As to your question about cancer diagnosis within 60 days of an abnormal result, that is a measure that is specifically connected to our breast and cervical cancer prevention work. That's work that is funded by the state of Illinois. So essentially, the state of Illinois gives us grant funding that we can use to subsidize cervical cancer screening and breast cancer screening for women that meet a certain income threshold. And one of the quality measures that we track with that is follow-up if there's an abnormal screening result. So again, that's sort of like an operational measure as well, I would say.
Thanks. Can I ask a quick question? Well, maybe it's not related, but since you actually talk about siren, I know that City of Chicago has like 200 air sensors all throughout the city. Do you know about that?
I'm familiar with that. So our agency is not responsible, doesn't have primary responsibility for monitoring air quality in suburban Cook County. I believe that may be either the Cook County Department of Environmental, I can't remember what the acronym is. It's DES, or the state of Illinois. But if your question is regarding air quality and what we're doing about it in general, please know that this is something that we take very seriously. And my colleagues at Cook County Department of Environment have convened a group that is looking at this issue.
Great, thank you.
Yeah. Director Masood Barnett.
These, I think metrics are good. I'm curious though, with the other that are more healthcare related, it seems like the targets are something they want to meet quarterly. In some of these are reach, right?
Yeah.
Like the number of workers reached, educated, or trained. And so I think the red, yellow, green is a little deceiving because it makes it sound like you're not, you're not meeting the work. But I don't know if there's a way to be clear about what your quarterly, are you meeting your quarterly?
Yeah.
Towards the.
Yeah, thank you for that question. I mean, this is where I think, one of the challenges for quarterly reporting for public health metrics presents itself in that some of our projects may unfold over the course of years, right? Some of the metrics that we track may not change for years, if not decades. So I think one of the challenges in terms of developing something that's suitable for this group is what would make sense for you all and for us to track on a quarterly basis. And it's really, we're trying to apply our best judgment in good faith in terms of setting these targets. Also know that this is really our first attempt at doing something like this, and we certainly intend to look at it carefully and refine as needed over the course of the next year or so. So again, you may see this change a little bit over time. Thank you.
Thank you for your efforts to try to operationalize some of these metrics that you can. So to see how you can manage and track those over time, and it gives you at least something to go on to let you know where you are, a benchmark point in time that you're moving forward with. So thanks for giving these down and kind of giving some ground rules for how you're moving forward with these.
Thanks so much. I appreciate that feedback. I just want to acknowledge Nandini Roy Tayabali, our manager of accreditation and performance management, who's been doing a wonderful job of helping to pull all this data together. Thanks.
So this is Dr. McCormick again. I will just try to finish up on this. I just wanted to say something is that I'm very pleased to hear the conversation that's going on in the room. What we try to do with our system quality, working with Raji and our BI team, is exactly this, and that is represent Cook County Health System as a system and try to put some operational teeth behind everything that we do so we can show you on a quarterly basis and a set cadence the progress that we're making in all the domains that Cook County Health System oversees. So I'm very pleased with the conversation. The next scorecard, I believe, is it County Care? Yes, County Care. I don't believe we have anyone from County Care in the room, but I think the
There's
scorecard
someone
speaks
here.
for itself.
There's someone
Oh.
present.
Okay, good. Well, I think County Care is, has a good lead up. They're showing progress. And this is what you would typically see in a scorecard, the beginning of the year when we're starting. And then as we progress, we'll start seeing improvement. But I won't steal anyone's thunder. Let's go ahead and hear from County Care.
Good morning, Dr. McCormick. This is Dr. Audrey Tanksley. I'm the Chief Medical Officer of County Care. Thank you for the setup here. So what you're looking at here is County Care scorecard. I think there's a little bit of challenge in the way that we present this, but it does show some significant improvement. The challenge is that we track these measures quarterly, but we track them against what we are doing overall for the year and towards that yearly goal. So as you can see, our targets for 2026 are listed here. For Q1 and Q2, we've been improving over time. It's not reflected here, but if we compare Q2 of 2026 to Q2 of 2025, we're actually tracking above where we were last year. And so we're really pleased with the progress that we're making and expect to actually meet those targets by the end of the year. The metrics that you're looking at are all metrics that help us along our 5-star goal and our HEDIS metrics. So all of these are areas that we are actively working on through care gap closure, as well as through increasing our reach to other providers and getting more supplemental data in to actually reflect the work that's being done with our County Care members. I'm happy to take any questions or on any of the specific measures.
Just a quick question about follow-up after hospitalization and ED visit for mental health concerns. When you say follow-up, is it like a follow-up clinic visit, or is it somebody just reaching out to you? What do you mean by follow-up?
Yeah, no, that's a great question. So the follow-up after ED visit for mental illness can look a couple different ways. It can be successfully completed in a telehealth encounter. Additionally, face-to-face encounter in person can also meet this metric. We do have some of our care coordinators within the health plan that carry the licensure to be able to make phone calls and do follow-up assessments with our members as well too. So at times that may be part of the follow-up, but we have good relationships with our community partners as well as some of our telehealth providers in order to help those members get connected. We're actually working really intensely now on our transitions of care programs so that we can make sure that we are filling the gaps of individuals who may not be seen directly afterwards. So we're actually improving that so we can expand our reach in that area.
Thank you.
Yeah, I want to make an observation in looking at the numbers, in fact, all the numbers. In terms of percentages, they may seem low in some respects in terms of what we're expecting to do, but they are ambitious, actually, in terms of what you're hoping to do. But I would assume that we know that these may be unrealistic in some respects to get the kind of, particularly when you look at high blood pressure and having a target of 75.43% people that are hypertensive under control. That's very ambitious. But I think what it means is you set the bar very high. And what may be inconsistent with this is our ratings in terms of quality are high. So the numbers might not reflect it in terms of what our goals are, but we seem to be performing at a high level based upon external.
Thank you
Great.
so much for that observation, Director. So they are based on the percentile. So the 90th percentile, that's kind of how we choose that. Our goal is to have 5 stars in those areas, and so that equals to the 90th percentile. I
Right.
would agree with you that some of the metrics, especially those around chronic disease, are a bit more challenging to achieve. But there are specific definitions that equal that rating. So, for example, with the blood pressure, controlling blood pressure rating, that is that can be achieved by one measure that equals less than 140/90 during a visit. Where we see the challenge is someone may be controlled this month, and then when they go back to their provider in 2 or 3 months, the rating may be higher, and then that takes away from that because it's based on the last readings that we have. So to your point, it is a big effort, especially the blood pressure as well as the glycemic control that we really are working with our community partners to get better data from, because sometimes it's a lack of having that data as opposed to the control that the member actually has.
Yeah, but the patient has more control over these numbers than we do.
Absolutely.
That's the point.
Yeah, so I mean, I think there's evidence that about 20% of what we do in the clinic actually matters, and 80% is what the member does when they're out, and not in the face of their healthcare provider. So we do work with our provider partners on education and self-care management. We're actually with our new contract in the process of building a condition management program around a lot of these chronic conditions as well too, which will help to give the members more self-care.
But we set the bar high, and that's what I'm applauding you on. Set the bar high.
Appreciate that. Thank you.
And you can see a notable improvement just in Q2 from Q1 as well, let alone your discussion about the numbers from 2025, what those metrics were. So you know that you're moving in a positive rate.
Absolutely. And a lot of these metrics are dependent on supplemental data. And so it's pulling that data from those additional provider networks in order to actually get it into our system. But we're very pleased with the progress we're making.
So I'm a little confused about the red to yellow. It's a little bit confusing because, if you look at breast cancer, 2025, it was 57%, and now we're like barely 50%, but the color changed from red to yellow. But actual number, in a way, when you think of it, it's still like below 2025. I don't know, like comparing from low number of Q1 to low number Q2, but because it's like 0.5% change, you turn it into yellow, but when you think about actual number, it's like way below 2025,
Yeah, it's not based on it's a percentile change. And so when we're looking specifically at breast cancer, it was 55% for calendar year 2025. We're just in the second quarter of that, and we're already at, to your point, 50%. So as we continue to progress and get additional data in, we expect that number is actually going to exceed the 55%. But I understand what you're saying. Yeah, it is confusing. I think it was a little challenging for county care to fit the standard model, but we wanted to be, of course, consistent across all the departments.
And Dr.
Yes,
McCormick,
so-
you have your hand raised.
Yeah, just a little point of explanation. So I think that's a very good observation. And there's really 2 ways that the end user has been interpreting the red to the yellow. To your point, if we were to standardize across the entire board, some of these metrics would be in the red because they're not better than they were in 2025.
Might be better for them to clear.
Right. So they're better. On the Stroger scorecard, what you saw was if they're yellow, they were better than the year before, but they're not at goal. This, however, you could see and I believe this is what we were referring to. If you continue this rate of rise, you're progressing towards being better than you were the year before and hopefully at goal. So getting to goal. So it's really the rate of rise versus is it absolutely better? My personal preference is to standardize these, and I think this is us kind of perfecting this as we move along, as we said we would. And my preference would be to have that only turn to from red to yellow once we surpass the year prior's goal or year prior's performance. So that would be, to your point, would still be red, but anticipated yellow or green throughout the year. I hope that helps.
Thank you.
Yeah, but when you color code it, it implies some things that you may not intentionally mean, that's all.
Well, I agree, and that's what the conversation is for, I think. There's nothing that's going to be perfect, but I do think this is significantly improved and a much more readable dashboard and format for us in this forum. And I hope everyone is in agreement with that. We're open to changing.
Thank you.
All right. And this is Cermak.
Good morning. My name is Kevin Hickey. I'm the Director of Quality Improvement at CERMAC. Mr. Estrada's on vacation. He asked me to represent him. So these metrics in part reflect the requirements of our accreditor. We're not Joint Commission accredited. We're accredited by the National Commission on Correctional Health. They also are relative to our unique environment. Safety and security is the primary focus at the jail. So we are impacted if there are issues with resources, primarily DOC resources to move individuals so they can be seen by our clinical staff. The first metric, the only one on our dashboard here that's red, addresses medication compliance. And while we would all expect that 100% of the medications ordered are being administered, we have situations where that's not possible. That includes situations such as a DOC lockdown. There may be no movement within a division for a weekend in some cases. There is daily communication between Mr. Estrada, his operations staff, and DOC representatives regarding who we can move to various locations so that we can get individuals treated. That includes moving people from the jail over here to Strozier if they have appointments. And it's very challenging if there are periods when DOC officers are not available. While the metric shows for the first quarter 93%, second quarter 94%, I want to reassure you that the individuals who are in our infirmary type setting, that's the CERMAC building where we have the psychiatric patients and also the more acute medical patients, they are seen at a much higher, they're receiving medications at a much higher rate. That's exceeding our goal of 96%. The lower percentage is actually primarily impacted by two of our more notorious divisions where there are those actions, where there are fights and lockdowns and things. So unfortunately, their volume of issues is significantly impacting this metric. The other metrics we have, as I mentioned, are relative to our accreditor. There are areas where there are yellow. Health service requests within 24 hours, we have to have eyes on an individual who was submitted a health service request form. That has to be done within 24 hours. Our shortfall there, again, can be impacted by Department of Correction resources and also our nursing resources. However, there's been a significant hiring activity for nursing at CERMAC, and we look forward that future quarters would not be as impacted by our staff. The grievances, we've implemented a change in process where we now have daily continuous processing of grievance rather than what was being done in batches. So we're performing much better than our goal of grievance resolution within 15 days. However, there's an area where we still have an opportunity to address those outliers that exceed that 2-week turnaround time. I'd be happy to address any questions you have.
I guess my question is about, people coming out of CCDOC, going into inpatient, bed, or, there's involuntary medication by court. So these are, like, who initiates those? Like, how do you, like, actually include these type of, certification, petition, or court order into your, safety?
These are coming from our psychiatrists.
Okay.
The second and, the third and fourth metric are all relative to the mental health population. So, Dr. Bednar's is our chief psychiatrist, and they would come from him and his team. The request, there's a belief that a higher number of patients would benefit by placement in these settings and also by receiving the medication. So, they're the ones who initiate with the court, and they've set a goal of expanding the volume of patients that would be benefited.
Great, thanks.
Okay, thank you.
Okay, thank you.
And I think that completes the scorecard review. We might want to check the next slide just in case I'm skipping somebody.
Nope, that's it. That's
Excellent. And so I have Raji and Andrea, if they could make some closing comments on our status and then move through.
Good morning. My name is Andrea Ramel. I'm the Director of Performance Improvement. You had a really great opportunity this morning to look at the scorecards from all of our sites. And in closing, I just wanted to share a little context in terms of how those scorecards are being utilized in our new structure. As Dr. McCormick mentioned, each site has set up councils, and then those councils are focusing on those items in purple that will have the highest impact in us meeting our goals in our strategic plan. And from those councils, we've set up work groups to address and drill down on specific measures. And just as a quick example, I had an opportunity to connect with one of our ACHN work groups yesterday, and they were focusing on hypertension management, and they took that sort of overall score and looked at it at the clinic perspective so they could see across their clinics which areas were performing best. They went to the Gemba, so the place where the work is being done. They talked to the providers, they talked to the staff at that clinic, and identified an opportunity related to how blood pressures were being documented. They then took that information back to some of the clinics who were performing lower on that measure and created standard work on how to document those blood pressures, and they are seeing improvement. And so they're now studying that and then plan to take that to the rest of their clinics. So that's a great example of how we're looking for this structure to support us achieving our goals and really engage our frontline team members in understanding what our opportunities are, what we want to test, and then studying that and then spreading it for sustainment. So we wanted to just share a little additional context related to how we're seeing these things start to play out.
Any questions related to how the strategic pillar on quality, safety, and experience is being cascaded down to the front line? We would be happy to bring additional examples of success as we roll this out across the system.
Well, not a question, but an observation that none of this would be possible without the active involvement of staff. And so we have to applaud the people that are parts of these committees. I mean, that's work above what they should do because they have a job description, a title, work they have to do, and in addition, they're doing this work. So it reflects not only the work they do, but their commitment to quality.
And Director Harrington, we are being very intentional about including frontline in this improvement work. We want to make sure that this is not top down, it's bottom up, with support from the leadership.
And it shows.
And it's inspiring to see that engagement. So we're lucky to be able to see that every day and then share that with you all, because absolutely agree. We have great people here. Thank you. Thank you.
Thank you. All right, the committee will now go into a closed meeting. Action is not expected to be taken in the open session after discussion in the closed session. Can we have a motion to go into a closed meeting pursuant to the following exceptions to the Open Meetings Act, number 5, ILCS 2120-2, C1, 2, 11, and 17?
So moved.
Second.
We need to do a roll call. All right. Can we please have a roll call, Madam Secretary?
Roll call vote on the motion to go in closed session, aye or nay. Director Kim?
Aye.
Director Masuda Barnett? Director Harrington?
Aye.
And Acting Chair Sorrell?
Aye.
You have 4 yeas and 0 absent.
All right. The motion carries. We'll now go into closed session. Thank you very much.